It is indeed our honor today to have Dr. Lee with us, and please join me in welcoming her for her talk. Thank you.
You said you leave before I have a chance to say thank you. Thank you, Suni, for a very kind introduction. First of all, I would like to thank the organizer, Dean Laurie Macaulay, Dr. Mistrata, and the organizer for the opportunity to be here. Actually, it's an honor and pleasure for me to be here. I feel very, very special. I'm standing here and I'm looking at a diverse audience. Some of the faces that I recognize, some of the new faces I just met. I met so many very, very promising students in both combined DDS and PhD, as well as the DDS student. They are the future generation of our dental field, and I feel so blessed. And actually, I'm very, very excited. I have long conversation with them. I almost forgot that I have a lecture today. That's why Charlotte just came and grabbed me. And you need to be a little bit more disciplined. You better go to the lecture. But this is my passion, okay? My passion is I want to be able, okay, to share my knowledge, to guide the future generation. Some of us, they are just starting to step into the field, and they want to know, is academic dentistry out? Is this a career path that I want to choose? Yes. I want to be able to help them and to provide them tools or any experience, any knowledge that I have, that I want to be able to provide that. So I'm here to communicate and connect. So this is what I will want to share with all of you. So today, I picked the topic of orofacial stem cell tissue regeneration and beyond, and I choose the topic of orofacial stem cells, not any other stem cells, because I'm a dentist. I'm going to share with you, when we look at the stem cell timeline, stem cells field is not new. In 1956, the first bone marrow transplant was done. That's the beginning of what we understand about stem cells. And we already put in application. We probably put in application before we understand the deep, mechanism. So it's out there in 1956. And I go to all this landmark, all the year, mouse embryonic stem cells, the human stem cells from adult mouse, stem cell from adult human brain, okay? Human embryonic stem cells that was discovered, reported. And then I look at how about stem cells from the orofacial. We start 1956. The first stem cell from adult human brain is 1992, around that period of time. We didn't report anything on stem cell derived from oral tissue until around 2003, 2004. Okay. And instead of all those advances in the stem cell field, how much literature is on orofacial stem cells? Most of us, when we step into stem cell research, we feel comfortable doing stem cell research using the most established cell line or stem cells, bone marrow stem cells. If we look at the history, how stem cells field evolve, so much on the adult stem cell. Lots of focus on bone marrow stem cell, some on adipose stem cell. Adipose stem cells start even after us. But look at how far they go, how fast they go. So as a dentist, as a clinician or surgeon, I ask that question every day. And I want to be able to expand that knowledge in orofacial stem cells beyond what we currently have. So I start my journey with these pictures that I always tell our students is everything starts from this journey. The journey starts from a zygote, when the cells undergo division, and it keeps that totipotent cells, but they not differentiate, right? Each of us go through this journey ourselves. Do we remember? So maybe I explain to my students because we never differentiate at that point, okay? So we never remember that journey that each of us undertake. So basically, the history of human embryonic stem cells start from that. When cells were obtained from the inner cell mass, when it's still in the blastomere phase. So that's the beginning of the human embryonic stem cells. But that is just introduction. I'm not going to focus on this. I will be focusing on this. Okay? So adult stem cells start much later. Well, we do have some political issue that we were banned from doing research or developing new human embryonic stem cells. Maybe it's a curse and a blessing. It's a curse that we probably behind, but if you think about the blessing, there's so much finding in how do we understand deep into the mechanism of differentiation and de-differentiation from specialized stem cells or specialized tissue. This is a blessing, right? Otherwise, IPS will not be discovered. We will not be able to understand. I remember my first lecture when I attended at Scripps Institute in La Jolla. They told me that differentiation has to go by lineage commitment. There is no de-differentiation. At that time, I have to agree, because there is no other way. I'm listening to the stem cell specialist, and I was a beginner in stem cell biology. But now, 20 years later, we learn so much. Can we de-differentiate? Yes, we can de-differentiate. Can we trans-differentiate? All those are challenging questions, but it's doable. So we can reverse a cell. From a cellular level, we can de-differentiate. From an organ, can we regenerate a new organ from a human? That's the next question that we will have to debate. Maybe, probably 20 years from now, that question will be out there. The answer will be out there. So to start with, we have brain adult stem cell, heart adult stem cell, bone marrow. This is the most characterized one. The dental stem cells is the one that we will be focusing our attention today. And those of you who are familiar with this history, we all start from this beautiful fairy tale tooth story that start from the group at NIDCR who used the deciduous tooth from the daughter of that investigator and able to generate, develop, isolate, and characterize the first stem cells derived from that deciduous tooth. So when we look at the pattern of differentiation, stem cells go from totipotent that we're talking about, that zygote phase or the early morula phase, to pluripotent. And it can become more committed to different adult stem cells. And what we talk about, people study more about mesenchymal stem cells. Some of us want to talk about other stem cell like epithelial, which is less characterized. And it's continue that journey to be more specialized stem cells. But now we understand that we can deprogram that from differentiated or committed, fully committed cell type to something that is a little bit more progenitor or stemness, which is known as induced pluripotency. So this is all my basic biology of stem cells that I have here. One more. I want to share with you this concept that I talk in terms of, when we look at the embryonic stem cell or any kind of pluripotent cells, and we see that they differentiate into different specialized cells. What are common about this? What do they share in common? What do ES cell and pancreatic cells or bone, any specialized cells share in common? Are they different cell type? Yes, they are different cell type. Do they have same DNA? Yes, they do have same DNA. They have different gene expression. So what regulates gene expression? What determines the path of differentiation? I guess that question starts to be unfolded when we understand more about epigenetic regulation, how the microenvironment regulate or control gene expression. They are the same, they do have the same DNA, but they are just specialized or differentiate into different function. So today I want to focus or give some example of what we know about orofacial stem cells. And I picked some of the MSC that derive from tooth as well as supporting structure. These are well characterized: human apical papilla or scab, human dental pulp or DPSC, human exfoliated deciduous tooth or shed, human periodontal ligament PDLSC, and lastly human gingiva or gingiva MSC. Some of those functions are some of the highlight that I want to touch a little bit in this lecture. Of course, I cannot forget about regeneration, so I will talk a little bit about regeneration. I want to focus a little bit more on immunomodulation, which is something that's very close to our lab. I want to also introduce a concept of benign tumor stem cells. We work a lot on cancer stem cells, in all the organ, tumor. They talk a lot about cancer stem cells, but how much out there in the literature that people talk about benign tumor stem cells? So that's a relatively new concept, and I want to drive that, a little bit more, because as clinicians, we treat a lot of benign tumor in the orofacial region, not only cancer. And then I touch a little bit about clinical trial. My clinical trial that I'll be talking probably is not much out there when you look at orofacial stem cells. And I would like to engage some of the folks here that I have a chance to meet today who work on clinical trial using bone marrow MSC. I want to draw them in. Let's work on orofacial stem cells in clinical trial. So we start with orofacial stem cell tissue regeneration. So basically, I'm going to quote this paper. That's the first paper talk about shed stem cell from human exfoliated deciduous tooth. And we're familiar with this history a little bit. When the PI isolate, the cells obtained from the, the tissue from this, baby tooth of the daughter, and then, basically, try to create an environment to allow them to differentiate into different, specialized cells. Here we look at here, this is a tooth structure here. You can see the pulp, and again, this is odontoblast, the lining the dentin, and using that, they're able to identify those clones, multi-clones of stem cell MSC. These cells, depend on the environment they're in, they can form sphere. That's reminiscence of human embryonic body. When they are under environment that are attached, they will show more like mesenchymal or fibroblast-like structure. And again, when you look at proliferation, of course, they have chance to proliferate much higher. And if you compare with bone marrow MSC, shed has tendency to proliferate at higher rate. And you can keep them in the culture for a long time too, because we work with shed, and this is an easy cell to grow and propagate. So if you talk about propagating in situ, ex vivo expansion for any kind of cell-based therapy, this is a good cell line. Next, review again on stem cells derived from the human periodontal ligament. Again, this is the third molar. So when they extract the third molar, you can see beautiful periodontal ligament attached. So basically, you can take these tissues and isolate stem cells from that, form colonies, stand for different stem cell marker. You see, STO1 and CD148. And you can see that, in terms of what they can present, they express different markers for sclerosis, which is ligament. So they use that at that time because we don't know what periodontal ligament express. And after I talked to some faculty, we have new biomarker that we can use, but that's next. But in the past, that's what they used, sclerosis as some kind of ligament protein. And again, they always confirm that proliferative behavior of cell renewal. And again, in vivo, when you do those kind of xenograft or ex vivo xenograft implant, they can form different structure that reminiscence of dentin or periodontal ligament, as you can see right here. This is bone marrow, so you can see bone marrow. They bone marrow MSC make basically bone, marrow component versus our PDL stem cells will make dentin and the odontoblast rimming. So I just want to introduce some of this work from this group that they show that they were able to use MSC to generate some kind of tooth structure. So they burrow swine, they have to apply in the pig model. So, dentists do this. So we know we're familiar with the dental structure. So they extract incisor from the right here. Okay, they create scaffold that's very similar to a root. So they call a bioroot. Okay, and then they have scaffold like HATCP and scab. That's one source of stem cell that they use to coating that. And they create inside. Actually, they have different structure inside that they use more like the shed that they put inside. And they implant back in the freshly extracted extraction socket. Okay, suture, close it, and at some period of time, then they have to create a crown structure. Again, dentists do this because we know the dental principle, how to create bioroot, how to reconstruct that bioroot with some kind of crown structure. So they have to put a post in it. So basically, that's what they create. So they were able to create a crown that was supported by a bioroot. Again, when they do CT scan, they see a little bit of that structure that you can see. The periodontal ligament was there, and then they confirm with the histology. You can see dentin, periodontal ligament, and again, you have to test that compression in terms of the compressive force and see whether this bioroot sustain the same kind of compression as a normal tooth. And this is normal root, and this is bioroot, and this is scaffold only. I mean, this is like, more like a case study in the minipig. But I think it just established, a principle that we could, probably develop further and design the study in a more organized control study to ask that question, can we do this? And another study by Yi Liu in stem cell in 2008, here they do periodontal regeneration with PDL stem cells in minipig. Again, this minipig model is the ligature ligated vertical bony defect with the PDL treated group. Clinically, they see the nice gingiva here. With the scaffold group, they see some regression and some clinical demonstration of that defect. And with control group, of course, you see a little bit more defect right there. And that's confirmed by the radiographic study. So basically, I just review a little bit of, which is very, very superficial, I have to admit. There are more literature by other groups that working with similar orofacial tissue stem cells to conduct some kind of preclinical study in probably mouse, rat, and minipig. So next question is, we know I have to borrow this. I apologize, I have to borrow this from the bone marrow. I have to design my own and put a tooth here, which I did, but it's still in production. So this is a very, very familiar picture to most of us who work in bone marrow stem cells. We know they are multipotent. They differentiate in any tissue that I want them to differentiate. Just find the right environment. Okay, then you're able to manipulate them to differentiate into different tissue, specialized tissue and organs. What I'm interested in is this part. I'm interested in the ability of mesenchymal stem cells to immunomodulate. And there is a nice review by this group. So basically, it is known that MSC, probably bone marrow, that capable of suppressing or promote certain component of the immunity. For the adaptive immunity arm, we know that they suppress the T cell. Okay? In some new study, we know they can suppress Th17, Th9. They suppress those inflammatory T cells. They promote regulatory T cells. Okay, you can see the balance between Th17 and Treg. That's how we regulate inflammatory response. As well, Th9 and Treg, we see that balance in that. And stem cells is capable to perform that function. In terms of the innate immunity arm, they suppress natural killer cells, but they promote neutrophil. They suppress macrophage. They suppress dendritic cells. And there's new study actually from our group, they suppress mast cell. Okay. So at some point, I have to revise this schematic illustration a little bit to represent new data, because you can see that's 2009. So I want to introduce these cells to you. It is stem cells derived from gingiva. Aside from multiple differentiation to different cells that can perform that regenerative function that we see, these cells are also very known for immunomodulating property. So this is how the cells were isolated from the gingiva. Today I have a lesson in terms of the gingiva, you know, where does the gingiva is obtained from. You know, it's so nice when you, among periodontal, you know, a colleague who can tell you, you know, which part of the epithelium is unique in terms of the, you know, periodontal, you know, attachment. I did not know that, so I'm learning so much today. But anyway, this gingiva was obtained from actually gingiva cup. Most of the time when you extract a tooth from patient, okay, even if you use a periodontal, you know, program, you just try to sever that ligament, you know, attachment. Sometimes you have a cup of gingiva that attached to it. Either that, or you can take that, you know, a little bit of papilla and you just snip it a little bit. Most of the time, these are discarded tissue. I call it discarded tissue. So I use discarded tissue to derive this special stem cells. So this stem cell is interesting in terms of, you know, same thing, they, you know, the mesenchymal property. In terms of sphere formation, if you put in them and the ultra low, you know, dishes without attachment, they form sphere. Okay, so, and it's interesting because in terms of the phenotype, the surface phenotype, the spheroid part of the gingiva MSC display different stolen, you know, percentage. They do maintain a little bit more stemness, okay, than the adherent component. Okay. And these cells, as I mentioned to you, they're capable of differentiate into different tissues or function as other cells. They can make neural cells. They can make endothelial cells. I share with you the immunomodulatory function of these cells. We test them in vitro. So I want to show them basically the immunomodulatory function in vitro using different bone marrow, different PBMCs, just peripheral blood cells that we use, and then we just expose them to different you know, environment to make them differentiate into different components of the immune system. And then we co-culture them, cell-cell contact or to transwell. So we look at different questions, transwell, paracrine effect versus cell-cell interaction. And we can see that with gingiva MSC co-culture, they can surpass, you know, any stimulated PBMC. They suppress Th17, as you can see right here. You know, they can suppress when you add them co-culture. They suppress Th17 expression. They suppress mast cell, as you can see right here. When we activate them, you know, to fully, you know, enhance them to exhibit property of mast cell, when you co-culture with gingiva MSC, you can suppress that mast cell. But they promote Treg. Okay, so this is just very, very quick in terms of briefly introduce their function of what they're capable of. And I summarize this a little bit in terms of ex vivo expanded gingival MSC. Interaction with the gingival MSC, you can see suppressed mast cell, it suppressed macrophage. I go a little bit more. The other study that I did not mention that we go into different subtype of macrophage, M1 and M2. And it shows certain ability. It suppress M1, which is more like inflammatory macrophage, and wound healing M2, which is the more healing macrophage. Overall, it suppressed, dendritic cells. It promote Treg. It suppressed TH17. And we look at distal homing that I was not able to share with you today, but I just, composed this summary of what they're capable of in terms of, how do they exert the function when you treat them or you, were able to infuse or administer to mouse. So bottom line is I introduce a concept that, whatever function that they are doing, they're performing a function of orchestrating the environment they are in. So basically, the paradigm shift that originally when we know about stem cells, is an old concept as we're thinking about we replace the cell of injured cells. So replacing one-on-one, are we replacing a one-on-one? So we just replace whenever it's injured, we replace it. Or are we creating an environment to promote repair and regeneration? Is orchestrating the wound healing environment to be more conducive to tissue repair and regeneration. So it's a little bit of paradigm shift when we go from concept that we understand of regeneration by one-to-one replacement versus create environment to regulate gene expression. I'm not moving here. Okay. Sometimes you have to freeze just to make sure you evaluate what did you do wrong. So anyway, so I like to share with you some of those models because I know that these cells, specifically gingiva-derived stem cells, they're capable of immunomodulatory function. So when I introduce that concept, I have to test it in some kind of model. So I create some translational model in mouse. So one of the model we use is chemotherapy-induced oromucositis. This is not my model, actually is established and widely used, and by Bruce Wong when he started on the mucositis study before. So it's been there, but I want to test that because as clinician, we see chemotherapy-induced mucositis in our patient pool. And this patient, when they have mucositis, it could be very, very dramatic that, they have to stop all their treatment regimen. And then it's compromised, cancer therapy. On top of that, more and more, we are leaning toward transplant. Transplant patients undergo huge chemotherapy for conditioning therapy. So they suppress. They develop oral mucositis, very, very ugly mucositis. My collaborator at Penn, he's a kidney transplant. Some of them are doing, they told me, Ann, come up with something, mucositis. How do we deal with it? It's no longer the only cancer-induced mucositis, but transplant-induced mucositis. But this model is chemotherapy, oral mucositis. So anyway, so this is chemotherapy-induced oral mucositis. This is the mouse patient. They have mucositis in the tongue like this. Okay. And the problem is when they have mucositis like this, they cannot eat, they cannot drink. So basically, they lose body weight. So that's one of the outcome measures that we look at when we conduct this kind of study. So you can see in terms of, like I mentioned here, spheroid, spheroid are adherent, they're all gingiva-derived MSC, just different component, different stemness property. But normal, this is non-treated, average body weight, fine. This mouse don't have mucositis. They fluctuate in their mouth because the way they eat, okay? But no treatment, they dramatic lose of body weight. When we treat them, this is only one treatment with just, IV infusion or intraperitoneal. And then they show some kind of improvement in their body weight. And these mice actually gain weight after a while. We don't have to go back and treat them. But of course, if we do long-term study, we have to do more prospective study, and we cannot do it in mouse. And here we show you both histology of this tongue. And actually, this is only one part of the histology. I look at from the tip of the tongue to the middle part of the tongue to the back of the tongue. And this is a question that I will have to ask Dr. Mistrati to help me on this part, because I observed something very interesting about this treatment, this mice. So basically in control, H&E, you see the filiform papilla right there on the mouse. With oral mucositis, we see sloughing of the epithelial. You see the loss of the architecture of that filiform papilla. But when you treat them, you see restoration. One treatment, okay? A little bit fancy. I collaborate with folks down Laser Beckman, UC Irvine. They have different probes that they put in the tongue of the mouse. They do optical coherence tomography for this kind of work, and they detect, breakage in the epithelium lining for the oral mucositis. So you expect something like this. You can see the basement membrane. You see epithelium layer. So that's basically what you're looking for. But OM is like this, and when you treat them, you can see some restoration there. And this is multiphoton microscopy. And it's interesting because it depends on where you evaluate the filiform papilla. Filiform papilla, this is more like, like the middle part of the tongue. You see sloughing of the old filiform papilla, but it reappears. It reappears, when we treat them with the Gingiva MSC. So in a sense, am I seeing regeneration because of direct repair, or am I suppressing inflammation? Those questions out there. All I know is the outcome is I see some kind of regeneration of some structure, taste bud in mouse. And I have beautiful, beautiful histology as well, fluorescent microscopy and MPM. We can play with the script, and I will share with you, Dr. Mistrati, on this. Is very, very interesting on this one. Next, I asked the question of other mucosal inflammation, and experimental colitis is one of the easy models that you can use, and you can create this mouse with colitis very, very fast. You just treat them with dextran sulfate. They develop sloughing of their intestinal epithelial, and they lose body weight. So it's a very quick model to address inflammatory disease if you want to test your cells. As I mentioned, you see the body weight. This is DSS, mean mice that are treated and exhibit experimental colitis. So you can see that body weight decrease, okay? And when you treat them either with bone marrow MSC or Gingiva MSC, you can see the less severity in terms of the body weight. They start to eat again. They can absorb, the nutrition a little bit more, so they gain weight. Take time for them to get there. And we measure colitis score, okay? And we measure leukocyte activity as well as other histological score. And we can see that with the treatment with MSC, either bone marrow, we always use bone marrow because that's standard. People always compare with bone marrow. But we want to know whether our Gingiva MSC does, the same immunomodulated function or capable like bone marrow. And when we look at histology, it's very impressive. This is a normal epithelial gut. You see, this is naive. You see, this is smooth muscle epithelial, and the crypt, everything is intact. With experimental colitis, you can see complete destruction of the epithelial lining. You see lots of inflammatory signal right here. Okay, I was surprised when I see this. I mean, this is not that impressive. Yes, they lose weight and they start to regain the weight, but this is very, very impressive. When I saw this, information, I was very, very excited when I see that. But is that surprising? I don't think it's surprising because they do have randomized study, double-blind, placebo-controlled phase 2 clinical trial, actually using multi-stem cell therapy being conducted for eczema, colitis, and Crohn's disease. So it's already, in progress. The difference is gingiva MSC. Okay, to me, that's the key, because we were able, imagine one day you can tell your patient, I can take your gingiva, just a clip, and I will be able to expand that and use the cells to treat you. I think that's something that's accessible, something that's doable, very minimal morbidity. I don't need to go to your hip and get your bone from your hip. So I think that's the concept. I also want to mention a little bit about the bisphosphonate osteonecrosis of the jaw. I work on this. It's not the topic of today, but I want to mention a little bit because we generate this model a while ago when we create the osteonecrosis by feeding the mice with Zometa and dexamethasone, both in combination. And it's very, very interesting because what we're seeing is when we, this is only one part of that paper, is we also try to treat with MSC to see whether MSC can enhance that, healing of the osteonecrosis of the jaw. In addition to other stuff that we study in the inflammatory component. But for the purpose of today, I just want to focus on, I'm going to use this as, the extreme. This is the white type mice, black 6, that we treat with Zometa and dexamethasone. Just pretend like you don't care about CD25. This is the story of the T-reg story. But this is, they form the ONJ, so they have exposed socket. And when you treat with MSC, you can see that enhanced healing of that socket. And it's confirmed by histology. Okay? And you can see that, bone formation versus this is necrotic bone. Okay? And then when you look at the radiograph, you see that, formation, nice bone healing in that extraction socket. And also because of my history, I used to be in wound healing before, I stepped into stem cells. I work with wound healing and keloid, so I cannot pretend not to, pay attention to that wound healing model. So I'm very interested in this too. So I want to try to see whether I can generate models to study wound healing, and the intention is to enhance wound healing in, defective or compromised wound. And the concept go beyond that. Actually, we're able to understand a little bit deeper. Besides the fact that we treat with gingiva MSC, yes, epithelialization happens faster compared with non-treated, and it's proved by histology that with the treated gingiva MSC, you can see establishment of the epithelial is more rapid. But the story behind is the mechanism is go to the M1, M2 macrophage. We were able to demonstrate that gingiva MSC suppress M1, which is the inflammatory component, and enhance M2, which is more like the wound healing macrophage. Next, I want to talk a little bit about orofacial stem cells and dealing with autoimmune, disease. I cannot turn to that. I have to stay one place. So this papers talk about using shed to improve renal function in lupus mice. So basically, they using the systemic lupus phenotype in this mice, MRL, LPR mice. And then they infuse, stem cells. So basically, here they use shed. Mice is like patient. So we do look at all those, blood and serum factor of, lupus indicators. So we use ANA, double-strand, anti-double-strand DNA. So this is how this mice look like. Okay. So when lupus mice has high ANA level, when you treat them, you can suppress that ANA component. Okay, same thing with anti-double-strand DNA. You can see the same thing, and you can suppress that. Okay, look at kidney function. Okay, you see the same thing. You measure the protein level in urine. You know, when they have kidney failure in lupus, they spill protein. When you treat them with shed, you see that suppression or decrease in the protein spillage in the urine. Okay, same thing with creatinine level. You can improve that creatinine level with treatment in the urine, okay? But in the serum, you can see that suppression of that high creatinine level in the serum. So that's indicator that we did something, we improved renal function. And again, you know, those of you familiar with the histology of the renal, the glomerular component, you can see that, you know, here is the lupus. You can see there's a lot of, like, the structure, the architecture is no longer organized. You see fusing or disruption of the basement membrane, and you can see proliferative, you know, mesenchymal cells. And when you stand, you can see some kind of fibrosis. As over here, you can stand with PAS, and you can see that, you know, very unorganized structure of that glomerular structure. But when you treat them with either bone marrow or with shed or facial stem cell, you can see re-establishment of some kind of architecture component in that capsule. At least you don't see that, you know, disorganized basement membrane and, you know, like absence of fibrosis. Another model that we did actually working on is the arthritis model. Actually, when I was at SC, one of my colleagues in rheumatology and immunology, he approached me and asked me, can I use Gingiva MSC to treat my rheumatoid arthritis mice? I was surprised because most of the time we use bone marrow. If you want to do it, you just use bone marrow. It's more established. But he asked me, and he told me, you know what? I see the need because most of the time, you know, you can just easily use discarded tissue. And if you can use discarded tissue to treat RA, this is something that I can sell to the patient. So he has rheumatoid arthritis model that he established. This mice has inflamed joint at their limb like this. Okay, so we gave them Gingiva MSC from human. So he start treat first. He asked the question, can he prevent? So he treat them early, okay? And he can see here, well, fibroblast is always a control. You can see that, you know, like this is the model. They develop that day 18, they develop arthritis, okay? And in treated mice, they develop, but they develop much later. So he asked the next question, can he treat a little bit more early and see whether he can change that severity of the arthritis? So he did that, you know, on day 15. Remember here, we treated earlier than that. And he see that, you know, with Gingiva MSC, he can bring down the arthritis score in this mice. When he looked at the histology, I orient you, this is basically the joint. The model, you can see, you don't see a clean articular surface. This is one of the joint, phalange of the extremity joint. And you can see, you know, like very disarranged. You lose that structure of the clean articular surface. You see cell ingrowth, okay? With the fibroblast treatment, it's the same thing. You have the same issue with this, that, you know, it's very disarray. With Gingiva MSC treatment, you see a nice delineation of the articular surface. Okay, so we asked that question about, you know, can we treat? So we did treat, and again, you can see that changing, you know, in terms of the arthritis score and confirmed by histology. Next thing is also we talk about other model of allergic or reactive response. We use the contact hypersensitivity like contact dermatitis. So in the mice model, you can see this mice that has contact dermatitis, you can see inflamed tissue, thickening of the tissue. when you treat with gingiva MSC, you can see that changing. Remember, this is, like we create this because we constantly irritate the ear of the mouse, so it never go back to normal. Okay, to bring attention to this, you can see that on this immunohisto, you can see the normal ear is like this. Okay, with the hypersensitivity ear, you see present a lot of mast cell. Okay, and when we treat it, we can suppress that mast cell level, and then we quantitate, we pseudo-quantitate it here. Okay. So next, I want to introduce the concept of facial stem cell benign tumor. We see ossifying fibroma in patients, and the reason I picked this because we treat benign tumor more as our surgeon. Here we have a strong cancer program, but in most programs, we treat benign tumor more than cancer. So I think this is opportunity to, develop this, topic a little bit more in depth. We treat benign tumor. Sometimes we do have tendency to treat almost the same, depend on how aggressive is that benign tumor. So we resect. Most of this tumor we resect. Do we need to resect? That's another question. If we understand a little bit about benign tumor concept. So we take a tissue from these patients, and then we isolate stem cells from them, go into all this process to confirm whether they are benign tumor stem cell based on our criteria. And then we create, staining. Okay, this histology, this is original histology that we do xenograph. So this is a very common way to look at how OF, or ossifying fibroma, stem cells, whether they can generate the same phenotype as in human normal pathology. So we use a mouse xenograph. And you can see with jawbone, you see beautiful bone, connective tissue. With OF tissue, they have island of bone, just like, like Chinese character, like that's how pathologists describe. So in OF, we see similar histology as ossifying fibroma. Using this cell type, we're able to create animal model for ossifying fibroma, a tumor. And then we're able to clone, do further study, and we find out that TGF-beta, active TGF-beta, is elevated in this tumor. And we go further and ask the next question, if we directly intervene with the TGF-beta pathway, can we regulate that differentiation? So we were able to do that. You can see here, this is OF MSC. Okay, when we add TGF-beta inhibitor, we're able to generate bone. OF, ossifying fibroma, you have suppression bone formation, and you have more fibrosis, more neoplastic growth of that connective tissue component, but you have suppressed bone formation. So we expect OF MSC to have inhibited bone formation. But when we add TGF-beta inhibitor, we can regenerate osteogenesis. And this confirmed by in vivo model using that ectopic xenograph on the mouse again. When we add TGF-beta inhibitor, we can regenerate that normal bone structure comparing with the pathology of more connective tissue that's more dominant than the bone island. So this is very quick TGF-induced osteogenesis by run 2. I'm sorry, Charlotte is like notch 3. We want to explain why we have that neoplastic growth. And that neoplastic growth is confirmed by notch 3. We do a quick array, and we determine that not only TGF-beta signaling is affecting, but NOTCH signaling is affecting. And we confirm this with notch 3. We inhibit with TGF inhibitor. We can see we can suppress JAK1 and notch 3, which are the same signal pathway. Okay, we do that xenograph that I mentioned to you. When we treat the tumor or the benign tumor with TGF inhibitor, we can shrink that tumor. This is deeper into the mechanism that I'm going to skip for the time, but I'm going to go back later for you, which is summarized in this. So basically, latent TGF-beta is regulated under TSP, thrombospondin 1, under the epigenetic regulation of histone gene, and it will determine the active TGF-beta component. And downstream of TGF-beta component is Notch, Jack, and Run. And you can see Notch is activated, is more driven to fibrous tissue overgrowth, versus if it's activated and Run2 is activated, you have bone loss. So you have an explanation of why you have a benign tumor phenotype that is more dominant in the fibrous connective tissue and more suppressed bone. Just allow me a little bit on the stem cell-based therapy, regenerative medicine. There's not much to talk about this field using orofacial stem cell. I was able to get some papers, but you can see that the nature, they use the PDL stem cell, they create cell sheet, and then they just create the defect, the vertical defect, and grafting. And you can see, to me, it's not amazing to me at all. But this is published. As you can see, is there a change? I don't know. Again, this is very case study, very non-randomized. It's not much about that. However, there is a study that's going on out there using stem cell, but it's not done here in the US. I was amazed there's no clinical study using orofacial stem cells. So what I can capture is mainly something abroad. They do also pulp regeneration, and again, they have some data that they want to share with me. But again, it's done by abroad. So I really encourage each of us to be able to adapt this and go deeper into try to apply what we know about all facial stem cells, see whether we can carry out into translational clinical application to better serve or to better address the problem of the dental field. Okay. Just a quick word. Of facial stem cell from bench, bedside, and back, I demonstrate some of those clinical components that we use tumor, we go back to create models so that allow us to go through that discovery process of pathway and mechanism to develop new compound, new targets to harness certain pathology. So that's what I want to do. And we cannot do alone, but we have to work building a culture of commitment, the next generation of clinician scientists. We have to work together. There's no silo effect. Basic scientists come together, work with clinicians. We should be able to expand the boundary. We should be able to reinvent what we learn. What we know, what I learned 20 years ago in dentistry, I hope that we will be able to revise it or implement it or innovate it and create a new path for the future. So I call each of us, to working together to connect and advance our dentistry to education, research, and clinical excellence. And we cannot do it. Our power comes from holding hands. Thank you.
Thank you, Dr. Lee, for a very interesting talk. And maybe we have time for one quick question.
Thank you, An, for that very interesting lecture. And I'm proud that you're a surgeon.
Thank you.
Giving that type of... Do you see any difference between autogenous versus allogeneic MSCs in their activity?
Do I what?
See any difference in autogenous versus allogeneic MSCs?
You know what? That's an excellent question that we've been debating. To be honest with you, when I talk to folks that are doing clinical trial, they want to use that allogenic, which is less morbid to the patient. But with all facial stem cells, the morbidity is much less, isn't it? So I think with the use of all facial stem cells, I think we're capable. Most of the time it's a tooth, a baby tooth, or a wisdom tooth that you take it out. So it's less mobility to a patient than touch their hip. So I think, if there is some complication that associate with allogenic, autogenic is a doable option using all facial stem cells. Regarding the concept of allograft, rejection, I think with MSC, the tendency is a little bit less. For some reason, with HSC, I think it's more, but for some reason, MSC, we use a lot of MSC, allergenic in heart, and like the expanded colitis is allergenic. Yeah.
Thank you very much.
Thank you.